I'm Dr. John of the Voyage Clinics podcast. Welcome. Today we have Betty Delass here, Dr. Delass, with us. She's a physical therapist and also a pelvic floor specialist. So we're excited to talk to her. So Betty, give us Dr. Betty, Dr. Delass. I go by Dr. John, but whatever.
Dr. Betty's fine.
Tell us about your journey into healthcare and into like physical therapy and maybe more details on your journey into the pelvic floor and how specializing there.
Yeah. So if you want a long story.
Go for the long one. Undergrad, postgrad, all the things.
So I started undergrad thinking I was going to be an actuary. Why? I don't know.
Work for the devil, basically.
Yeah. I can't even believe that. Because my chemistry teacher in high school was like, you should be an actuary. You're really smart and you'll make a lot of money. And I was like, okay, sure. And then I went to college and then, you know how freshman year they have a bunch of like meet and greets and like join this program, that program. Well, I went to like the actuary program and I was like, these are not my people. So I totally bailed. And then I was like this floundering fish of like, I don't know what I'm going to do. I'll just figure it out. And like 2 years go by, I'm a sophomore. I'm like, I should probably figure out what I'm going to do. So I talked to my advisor and they're like, you should probably take classes that you really enjoy. And so anatomy and physiology and all the things. And I was like, ooh, this is my place. Okay. And so started shadowing like, and then I was like, oh, I'm going to be an anesthesiologist because they make a lot of money. Totally. Yeah. I was really on the money path. Yeah. Turns out that's not what you should follow because it's not the right direction. So shadowed anesthesiologist was like, nope, definitely not what I need to do. What am I interested in? I went back to that. And I love exercise and movement and being healthy and things like that. And I like spending time with people. And so as a PT, you get to spend a lot of time with people, right? Yeah. And so I shadowed speech, OT, PT, PA, like all the things. And I was like, PT, that's where I want to go. So I applied.
Where were you at in the country?
Wisconsin.
So you grew up in Wisconsin?
Wisconsin. Yeah. Born and raised Wisconsinite. Go Green Bay Packers.
Let's go Packers. Let's go.
And so I was like, okay, let's reroute here. So I got my undergrad in kinesiology, exercise and movement science, and then applied to PT school, got in, went to PT school at UW-Madison as well, and then was just an orthopedic PT to start with. Like, cool. I started at Northwestern Medicine in Illinois, PT, doing my thing, and then we moved to Idaho.
How long were you orthopedic PT?
6 years.
Wow.
Yep. And then I switched to pelvic. After that. So over half of my career is now in pelvic. Okay. And so I had a really strong ortho background going into pelvic, which I think is very vital because it's all connected. Like if you're just looking at the pelvis, you're missing half of it. And if you're just looking at everything else, you're also missing half of it. Yeah. And so especially if you want to treat any condition around the pelvis there. And so I always was interested in pelvic health. Like we had one course in PT school that was like, oh, it's Kegels and biofeedback and that's it. Right. And I'm like, huh, what's this topic? And like I was interested. And so I did a part-time clinical in it, but I was always like, well, we'll see if the patient will let you in. And either I was standing at the head of the bed where the patient's head was, had no idea what was happening, or I was outside of the room because the patient didn't want me in there. So this was, 15 years ago. And so still this like curiosity. And I think it's one of those timing issues of like, it wasn't the right time for me yet because I'd asked at each of my locations I was working of like, hey, can I get trained in this? And they're like, oh, we already have someone doing that. Like, okay, but I want to do it and there's a need for it. And so it wasn't until after I had my first baby that I got to experience all the wonderful things postpartum myself with like peeing my pants the first time I sneezed and having painful intercourse the first time postpartum and diastasis recti and prolapse and trying to get back to running. And I was like, what on earth is this? And I got righteously angry. And that's where I kind of pivoted and shifted to pelvic health and women's health specifically because of my own like selfish reasons. And I was like done being told like, no, we already have someone doing that. So went down the pelvic health route there.
My wife doesn't understand righteously angry, but this happens to me quite a bit.
Oh yeah. Yes.
You just get fired and you're like, man,
in my soul.
F this, man. I want to do something better.
Yes. I'm like, I'm going to change the world. So
yeah. That's super cool. Yeah. That's super cool. And thanks for sharing your journey. That's really rad. Having the background in ortho, why did that help you be a better pelvic floor specialist? Yeah, so I think the ortho piece, because a lot of the pelvic stuff is low back pain, SI joint pain, pubic symphysis pain, and like your leg is connected to your pelvis and your rib cage is connected to your pelvis. Like it's all interconnected. So, and you can appreciate this as a family doc. You have to have that scope to be able to be like,
oh, this is connected to this and this is why you're leaking, or this is why you have this right hip pain is because this part of your body and this part of your body are making this not work ideally. And be able to talk to the patient in that way too. So I think having a strong orthopedic background really sets you up well for pelvic health. And then you can really specialize into pelvic health, but not forget the other pieces. So if you just started pelvic health, but have no ortho, you'd be missing some of the things, right? And if you just look at the pelvis, then like, well, what about that lat that attaches to that shoulder?
Yeah.
It's kind of a big deal.
Yeah. More holistic. That's really cool. That's really cool. What a cool journey and what a cool specialty. I really wanted to bring this up on my podcast just because I delivered babies for a decade of my career and really enjoy it. And then we see a lot of things postpartum, as you mentioned, like, and even pre-partum, even peri, like everything. We see a lot of pelvic health issues that I think we don't have great answers for in medicine.
Right.
And then we're just, like a lot of my OBGYN colleagues, right? And I'm a family doctor, but they're like OB, right?
Yeah.
And they're like, oh, another pelvic pain. Oh, jeez.
Yeah. And we're like, please give them to us. Like, this is our bread and butter.
Well, because chronic pelvic pain can be so many things. And I think once they've checked all the boxes as far as ruling out things that are scary, OBGYN related, then, okay, those aren't it. So
now what?
Then they don't have great answers because I don't know, is pelvic floor especially been around for a while? Because it seems like
30 years.
Really?
Yeah, it's relatively new in the field of medicine.
But it hasn't been on the upper parts of our brain waves for a while. Because most doctors are like, well,
just go.
I guess you're just going to be on chronic pain meds the rest of your life because
or do some Kegels.
No other, do more Kegels and stretch your whatever. So I think. How come it's been like kind of a hidden profession for so long? Like why is it a specialty that's like not a lot of doctors are aware of?
Yeah, I think there's a combination of things, right? Like I think it just wasn't a thing, and then someone got interested in it and is like, hey, can we blend these things together? And there's actually something we can do from a holistic side. And then two, I feel like generationally, like there wasn't a lot of chatter about it. It was a very taboo subject. Like we don't talk about this. Like hush, hush, like I'm not going to woe anyone with my private problems. Like no one needs to know that I'm peeing my pants, like, so I don't think it was discussed, right? And then now I think with the help of social media and the internet, there's a lot more access and people are speaking up about it too. And so that's kind of why there's more of a pelvic health like boom. So all of a sudden happening, which isn't really true. But from a social media standpoint, there's just more awareness around it.
Isn't that great?
And generationally too, I think things have changed. So like I talk about stuff all the time where my mom would have like never talked about that. She would have been embarrassed to talk about that.
That is true. Yeah. Those are cool things. So let's go over it globally, kind of what is pelvic floor physical therapy.
Yeah.
And then we can go into some of the most common conditions that you see in that space where I might refer to you for these things or a person might say, hey, doc, I think I need to see a pelvic floor specialist.
Yeah.
Can you speak to just as a specialty, kind of what does it cover and then what are the common things you see?
I'll walk you through like kind of what to expect when you come in to see us of like from an eval standpoint, what we're going to look at, and then all the conditions that we would treat around that.
Perfect.
Does that sound good? Yep. Okay. So you come in, we do a thorough medical background history, all things like that. And then we'll do a full body movement analysis on you. So we'll have you move all different directions, forward, backward, side, squat, balance, lunge. We'll look at movement patterns of like, how do you move as a whole person? What's happening there from a mechanics standpoint. Then we'll dive deep into each area of your body. We'll look at your entire spine. We'll look at your rib cage, your breathing patterns. We'll check out your abdomen. What's your core strength? Do you have diastasis, which is the separation of your abs? Yep. How are your organs moving? So we do what's called visceral mobilization. So we assess how the organs move because just like your joints move, your organs move on top of each other too. We'll look at your low back, hips, SI joint, tailbone, pubic bone, pelvis all the way down to your feet, all external at first. Then we'll switch gears and do an internal exam. So similar to an OB or a midwife or things like that, where it's an internal pelvic exam, but very different because we're PTs. Right. So no stirrup, no speculum. And we're looking at PT things. So like range of motion, strength, coordination, trigger points, scar tissue, pressure management, prolapse, and what's happening inside the pelvis, what's happening outside the pelvis, and combining those two things to figure out, okay, why are you having incontinence? Why do you have constipation? Why do you have pain with intercourse? And then all of those things like that to make an individualized plan of like, okay, we're going to address these things through PT to help cure or like fix whatever your ailments are or symptoms that you're having.
Cool.
Because usually a combination of both inside the pelvis and outside the pelvis.
I think this is why we resonate so well. So A, because of the the righteous indignation thing. Yes. But B, also because we're disruptors and innovators and we're very holistic.
Yes.
So listening to that evaluation is very holistic. You're going over
We're going over all the things. Yeah.
And then they're all related. And as a family doc, I'm very holistic, but then as an osteopathic family doc,
same wavelength
structure,
there.
Like things matter. And I mean, in my undergrad is similar as yours. Mine was like sports medicine, athletic training stuff. And very similar to kinesiology. So having that background, I'm always looking at like the way they're walking. And we do a lot more like physical evaluation as we evaluate their diabetes or their
you're like also adding those things in, which is awesome.
That's super cool.
Yeah.
So most common things that you see, age groups, like is there an age range that you usually see folks in?
We see women, men, and pediatrics.
Yep.
So that's almost a common myth. Like most people are like, oh, this is only for people who have had babies. Wrong, right? So from a female perspective, we do a lot of incontinence, diastasis recti, prolapse, pelvic pain, interstitial cystitis or painful bladder syndrome, persistent genital arousal, endometriosis, pregnancy, birth prep, postpartum recovery, hysterectomies, surgeries, prolapse repairs, pessaries, all sorts of things like that and probably 100 other lists of things.
Do you guys fit pessaries and stuff?
We do fit pessaries. Cool. Yep. And then from a male perspective, anything, again, pelvic pain, incontinence, constipation, penile pain, testicular pain, scrotal pain, post-prostatectomy surgeries, that's a big deal. And a lot of people don't realize that that's a very underserved population. There's a ton of repercussions from a function standpoint of incontinence and sexual function. And then for pediatrics, anything from like bedwetting, constipation, bowel movements at night or encoparesis, like all the things around that. And so we can kind of cater throughout the whole lifespan. And then also on the female side too, changing into perimenopausal, menopausal symptoms that happen with all of that too. We can help support that from a PT perspective as well.
That's a lot.
I know, it's so cool.
Yeah. Would you say, what are your top 5 that you see a lot?
Oh, top 5. Probably pelvic pain, incontinence, prolapse, like those would be up there, and as well as any orthopedic pain around the pelvis. So like low back pain, SI joint pain, tailbone pain, hip pain, pubic pain, that. Yeah.
Should we start with you for prolapse prior to like OB and stuff?
Absolutely.
Like stage 1 or 2 prolapse?
Stage 1 or 2 for sure. Stage 3 as well. Stage 4, we're going to definitely consult with a surgeon. If the patient doesn't want surgery, then we would do pessary from a conservative management standpoint. So otherwise we co-collaborate on a lot of that stuff too. Because we have to with the pessaries, because we can't prescribe estrogen cream. We can't do a speculum exam. Like we're not doing those pieces. So we need a medical management partner with the pessary. But from the mechanical side of things, we do all the pelvic PT, make sure the pessary is an appropriate thing, fit the pessary, make sure all the pelvic floor symptoms are resolved, because a lot of times people will fit pessaries and not resolve the pelvic floor symptoms, and the pessary is painful or it doesn't work. So we can really fulfill on that whole conservative management piece.
Cool.
Yeah.
Can you share maybe like a story with us now? I feel like it's story time.
A story?
Yeah.
Like a patient story?
Patient or personal? Like just something with regard to like pelvic floor and like, hey, we were treating this person or with this thing that we did these things and really helped them.
Yeah. It comes to top of mind. It's actually a male patient, not my patient, but we were sharing cases yesterday. So I'm going to share that one because I was like, wow, this is a really cool case. And so male patient, big into weightlifting, desk job, very sedentary outside of the weightlifting, but like working out 3 hours a day.
Whoa.
So like intense, right? Lifting lots of weight. Turns out he had pelvic pain, so from pubic bone to tailbone, just this general achiness, pressure, uncomfortable, and worse with lifting. Also had post-void dribble, so leaking after going to the bathroom, increased frequency urgency during the day and night, like waking up 4 or 5 times at night, and penile pain. So lots of treatment through that, releasing the pelvic floor muscles, recoordinating breath patterns and strategies during lifting, talking about lifestyle changes of like probably shouldn't chug 32 ounces of water multiple times a day and like things like that, getting pelvic floor to relax and coordinated, and also a little bit of hip pain in there too, worked on that. So hip pain's gone, now only peeing or urinating once a night to 0 times a night, not having any pelvic pain at rest, only and now able to max out and use Valsalva just when maxing out instead of all of the time when lifting. So like even bicep curls, Valsalving of like And so we've taught breath patterning and all the things like that. So yeah, that's where he's at. And that was one of the male patients that we have been seeing.
That's really cool.
Yeah.
That's really cool.
Yeah.
I love stories. I think they resonate with our audience.
Totally.
Kind of hear kind of what's going on. The common things like incontinence and things like that, like stress or urge incontinence.
Yes.
What are your treatment protocols for that kind of thing?
Yeah.
And do you have a story there as well?
Yeah,
because those are super common.
Yeah, super common. And I don't have a particular story in mind, but because it all just depends on like what's going on. Most people think, oh, it's stress incontinence. We just, teach to Kegel against that or whatever. And it's like, is it stress because of the pelvic floor? Is it stress because of the urethral sphincter? Is it stress because of breath patterning? So it can be a different variety of like, why is this person having stress incontinence? And the same thing with urgency. It could just be a simple urgency thing, or it could be a bladder related thing or a pelvic floor muscle related thing, or a behavioral thing where it's like key in the door, I gotta go. And so we have to really almost algorithm that out of like, okay, what's the root cause of this stress incontinence and what's the root cause of this urge incontinence? Because it's more complicated than like the surface level of that. And even I didn't know that early in my career. I was like, oh, it's stress incontinence. This is what we do. I would have been like, well, this is the protocol and this is the protocol. And now I'm like, wait, let's take a step back here because there's a lot of layers underneath this that we have to kind of work our way through to figure out like, okay, what's exactly going on with this patient?
That's cool.
Yeah.
I guess, how do we find a good pelvic floor specialist as we're kind of looking as family docs or as
Totally.
clients or whatever?
Yeah.
What's a good process there? And are all pelvic floor specialists roughly in the same as far
Created
as training?
No.
Because like it's family medicine. I know a board certified family doc has really good training in many, many things.
Yeah.
And we have kind of standardized like training processes and stuff. Do they have that in the pelvic floor space?
To some degree.
Yeah.
So there's institutes like Herman and Wallace and the APTA, which is our American Physical Therapy Association. They have training within those two institutions. Standardized to some degree. There is a board exam as well.
I was going to ask that. Yeah, some kind of fellowship or something.
And so those are all out there. I don't think I think at some point they'll have weight like your specialty does, where it's like, oh, I'm board certified in this right now. It's like, oh, I'm board certified in pelvic health. And everyone's like, okay, who cares? Like, it's not as well, like established or understood. Yeah. So I think our profession is getting more towards that, but it doesn't have any, implications of like more pay or a patient's going to come to you because of it, because they're like, oh, you're licensed PT. Great. Yeah. And so is all training created or all pelvic PTs created equally? No, because there's a lot of people out there that we see that have been to 3 or 4 pelvic PTs and we get told, oh, they gave me Kegels or they didn't do an internal exam or nope, they just had me doing clamshells on the bed. And I was like, what? Like it unravels me about my own profession. And so I think from a person, a smart consumer would do their research, right? Ask some friends, read some Google reviews, look around like that, ask people. And then it's not just like you would a mental health therapist, right? Like sometimes it's not the right fit off the bat and you have to kind of find your right fit. And so finding the right person who you can trust and like establish a really good relationship is the most important thing, right? Like your rapport with your provider and vice versa, your rapport as a provider with your patient is the number one thing. Mm-hmm. So I think making sure that you feel comfortable and safe and that they also have the skill set along with that too, to be able to dive into what's going on. Mm-hmm. Yeah, I think that's the most important piece.
You've done a lot with your team as a business owner. You've started out kind of as the technician, the only person there, and then kind of grown to how many pelvic floor specialists do you have?
I just hired one today. Yeah. So we'll have 12 at the end of February.
That's really cool.
Yeah.
And you've done quality control measures within your practice to like cross train and stuff. Yep. Is that mostly just you training and teaching like this is the way that I do it?
Yeah, to some degree. Mm-hmm. So we do use outside resources and send people to continuing education courses that are like, okay, you need to take this, this, and this. And we basically have your first couple of years lined out of like, these are the courses you're going to be taking. So it's a very robust like mentorship program. Mm-hmm. And then we also so I spend 2 weeks with each employee mentoring them. When they start out, I'm going over literally everything in my 13 years of experience, like condensing it down to be like, this is how you do this. And they're like, oh my gosh, I've learned more than I did in my entire PT school in 2 weeks. Like, what just happened? Like, you're going to drink through a fire hose, but it's going to be good. And we'll come back on it and refresh. And then they're paired up with someone else in the company then too, usually the clinical director, to also then do that. We do case studies, and then we do group classes together. So like this weekend, we're doing an advanced overactive bladder course, which is like the top course that you can take from an Australian physio. Cool. And we're really excited about that. So like we're all doing that together, which is really special and cool, because then we're growing together as well.
That's really cool. Yeah. I love that. We do a lot of didactics in my practice as well. We teach med students, we teach pre-med kids.
And we have 2 students right now too.
Yeah.
So yeah.
That's so cool. Yeah. That's really cool to have that academic environment there. Speaking of academic environment, the studies, the data, like the evidence here, can you kind of speak to some of that, like some of the practices in pelvic floor physical therapy and what the evidence shows there? And
I won't be able to cite any studies, but I can speak on the topics. So some of the things that obviously it's newer research too. Like we still have a lot of work to do in that space since we're a younger field. But some of the things that have come in are diastasis recti. Like there is a lot of like, oh, this gap, that gap, is this a gap? What should we do? Should we avoid things? Like a lot of that's been demythed. So like having a strong rectus during pregnancy and into postpartum is your number one predictor of success, versus like worrying about like doming or pressurizing and things like that. So,
really?
And so we've really shifted that fear mongering out. Same thing with prolapse, of people like, oh, I can't do this, it's going to make my prolapse worse. And it's actually with like research, we know that like standing and walking creates more pressure on your pelvic floor than doing like an ab exercise. When people are like, I can't do that, it's going to make my prolapse worse. So a lot of backtracking on like all the fear that's out there. And then when it comes to like incontinence and prolapse, like pelvic PT is grade A evidence on things, and to be sent there first versus surgery or medication. And then as far as like back pain, hip pain, like that's also, you're going to avoid shots, medications, things like that. Yeah. If you can, from a holistic standpoint, solve the root problem from mechanically speaking. Yeah. Fertility is another area of research. So like if there's a mechanical issue going on, obviously we can't change hormones or anything like that. But mechanically, if tubes are not patent and we can do some visceral mobilizations to help open those up, we can improve the habitat there, right? So like if there's pain or discomfort, we can increase blood flow, make it happier, and environment of like, oh, this is a good environment to grow a baby, versus being like, angry and all the things. Don't grow a baby now. Right?
That's super cool. Are there things that we can do to avoid poor pelvic health?
Sure.
And maybe promote good pelvic health, male and female? Like what are the things that we can be doing consistently? Some
basic things without like diving into someone's specifics would be obviously drinking the appropriate amount of water. So some people are like, oh, I pee all the time, I need to stop drinking water. That's actually an irritant to your bladder. And so getting the appropriate amount of water and sipping throughout the day versus chugging is important. Using a squatty potty when you poop to open up the pelvic floor. And then making sure if you're recognizing triggers, if you do have key in the door, like trying to change that. So it's not like, oh, I have to pee every time I put my key in the door. What's something else that people could do? Oh, early on, and some of this is too late for us, but before the age of 7 is when your hips are still developing and the growth plate closes around 7 years of age. So as much crawling as you can do is really good for your hip development. And that can help your pelvic floor tremendously down the road. So a lot of people who didn't do a lot of crawling or skipped crawling or sat W sitting, they have a lot of, I would say they're working upstream with their pelvic health just because of their hip development.
Okay.
Yeah.
Okay.
So that's
Kegels,
an early on thing.
How important?
So I would say 95% of the time we're not prescribing Kegels. In rare instances, it's like, that's actually what you need. Most of the time we're coordinating or lengthening and making sure people aren't tight in their pelvic floor.
So coordinating their Kegel responsiveness, is that what you're talking about?
That, or just knowing what to do. So like we'll have people who are trying to urinate or defecate and they're contracting their pelvic floor versus relaxing it and letting it go. And so making sure they know how to lengthen their pelvic floor just as much as they know how to contract it, and bringing that mind-body connection. Once they have the mind-body connection, usually we're going from, okay, you know how to Kegel and you know the full range of motion in that and you intrinsically know that, versus us like telling you what to do. And then we're loading them and we're making it functional because you actually use your pelvic floor. Your pelvic floor works as a system versus just in isolation. And so we want you to squat, we want you to lunge, we want you to deadlift, and you're actually going to strengthen your pelvic floor doing that with your breath more loaded than if you were to just do like Kegels.
That makes sense. That makes sense.
But in certain instances, it's like, oh yeah, we need Kegels for this.
Yeah.
Yeah.
What about like things that we can do for prevention or maintenance of like the pelvis, like yoga, Pilates, are you a fan of all of those?
Oh yeah. So we're obviously in the camp of movement. We want people to be moving and active and getting good sleep and drinking water and eating whole foods. But yeah, all of those things are great from a prevention standpoint. And just like being in tune with your body is half the battle.
Your thoughts on strength, stretch, or both? Strengthening, stretching, or both? Like with regard to pelvis, because I see a lot of pelvises that are overly strong this way or that way. They're anteroverted, retroverted. And so like, what's the answer there? Let's say like very commonly people are like
anterior pelvic tilt.
Anterior pelvic tilt. And so, so like for that equation, are you like strengthening or stretching or both?
It's hard to say. I err on like, I'm less on the stretching and more on like strength awareness, coordination, and stability more than even strength, because it's diving into those layers there where you can intrinsically empower the patient to understand their body and how to leverage their own body and use it versus being like, oh, we just need to strengthen this. It's like, actually, let's get you in a really good position so you can utilize your body in the best position. And that's at a mechanical advantage. And then you are able to then move out of that. So it's a little bit, I guess, more complicated than just like strength or stretch. Yeah.
What would you, like in a anterior pelvis, like would you like focus on what areas there?
So we'd probably focus on glutes. That's always usually off and not working the way they should. And then psoas on the opposite side and lengthening that. And then core strength too.
Yeah.
Lats, everything that touches
to pull
pelvis.
them up. Huh?
Yep. And getting a good balance around that.
A lot of them have really, really tight quads too.
Oh, 1000%. Yeah.
And then they're like pulling them.
Yeah. Sitting's the new smoking.
Yeah, totally.
Right?
Sitting's the new smoking. That's so true. So many of us are like stuck. And then our muscles shorten.
They shorten. Yeah. Because you're always in that position.
Oh.
So yeah. We encourage people to get standing desks, a walking pad underneath their desk, like making sure they're getting up and moving or have some sort of counterbalance to that.
So many back injuries and knee injuries and pelvic injuries and things I see are coming from like dysfunction at that pelvis site. And that's super cool that there's physical therapy that folks can engage with. That's really comprehensive in all these ways.
Totally. We get a lot of people too that are like, oh, I have knee pain. Like, where should I go? I'm like, here, we can still treat that. Like, we're probably going to treat it better than maybe an ortho PT because we have that whole background of how it connects into the pelvis and they're able to look at that.
Yeah. So how do you avoid being pigeonholed into just the pelvis? Like, hey, we're PT, we do all the things, but we also specialize in PT.
And most of that's like more internal marketing of like, we'll have patients come in and they love what we're doing. They're like, hey, my husband has low back pain. Where should I send him? We're like, here. Like, we'll see them. So we end up seeing whole families or friends or neighbors. We do get some hesitation because they're like, but they're like pelvis. And they're like, no, like talk to them. So our own patients advocate for us of like, they can still help you and they will help you amazingly and all the things. But we still want to be known for pelvis, like in pelvic care. And that's what we love to do. I always like to tell people like we're PTs, we're orthopedic PTs, and we're pelvic PTs. We're basically the nerdiest nerds of nerds. Yeah. And we couldn't stop learning until we arrived here. And we can also help with that. Yes.
That's cool.
Yep.
That's really cool. Some people, males, females, they might be afraid of like, what in the world? Like internal exam. Like, what are we talking about?
Yeah.
Can you walk us through that just to soften that touch a little bit?
Absolutely.
And maybe help people like, this is what it might be. This is what it will be like. You know,
So the therapist is always going to ask for consent. Always. We have both verbally and written consent every time with a verbal. And so it's different than an OB or a midwife in the sense that like no speculum, no stirrups, right? But we're gloved, one finger, lube, one digit exam, and we're assessing the muscles, right? So we'll might have you not even touch at first, and then we'll have you do a contraction, relax, bear down to see what your range of motion and coordination is. Then externally, we'll palpate on the pubic bone. We'll palpate all the way around in like a clock-like fashion on all the muscles externally. We might assess your inner thighs, like how's the tone in those muscles, because those connect into the pelvic floor. And then that's all external at first. Then we'll switch gears and do an internal, either vaginal or rectal exam, depending on the condition and the gender. And then internally, there's 3 layers to the pelvic floor. So the first layer is about 1 knuckle depth, second layer, second knuckle depth, third layer, third knuckle. And so if this is the pelvic floor, we're going in and we're assessing all the layers at each
interval.
At each interval, and then getting back on the posterior pelvic floor and getting all the way around.
Okay.
Yeah. We might have you bear down, see what happens with prolapse, contract your pelvic floor, breathe.
Is that vaginally and rectally, or is it one?
Depends.
Yeah. Males obviously only.
Males only one. Right. Yeah. But female will often access both canals depending on what's going on. If it's tailbone pain, like for sure, we're going to do rectal insertion because we can reach it better and we can hit some of those spots as well.
Keep them covered. You like do it kind of discreetly.
Drape discreetly, totally. You feel very comfortable.
Yeah.
There's no in doctor's offices where there's, the paper. We don't have any of that paper. It's like nice white linen sheets and it's cozy and we have a really warm, welcoming, safe environment. And we're always asking you and almost like pre-telling you as we go. I'm like, okay, I'm going to touch your inner thigh now. Yep. Okay, I'm going to touch your pubic bone. Are you okay with that? Like, may I proceed? Like, so we have an ongoing conversation all the time. Yeah. And then at any point in time, we always say consent is ever evolving. So if you're like, I think I'm done, we're done. And that's how it is. And we have a lot of people with a trauma background of things that we are very sensitive from a trauma-informed standpoint to make sure that that is respected and we have conversation around that before we would even begin.
That's super smart.
Yeah.
Yeah, super smart. Well, that's really cool.
And the pelvis holds a lot of emotions too.
That certainly makes me feel more comfortable coming to see you guys now.
Yeah, you're going to come in?
No, I'm just kidding. but sending folks or, because I just want folks to feel comfortable. I think there is an art to medicine and caring for people. And I do a lot of some of those similar things when I'm doing sensitive things with people. Yeah. And it's just, as long as you're talking, you're consenting. Important. And I love the ever evolving consent. Because if at any time you're uncomfortable, just say, hey, I'm uncomfortable. Let's stop this. Yep. And then we'll stop. And it's totally fine. No offense, no issues, just no big deal. Yeah. That's really cool. Because we don't know where folks' comfort levels are or if they're going to get triggered from previous stuff or whatever. Mm-hmm. And so that's really cool that you're sensitive to that as well. And also with our consent forms our consent and intake forms are very robust. And so they have opportunity to disclose anything like that in the process. But a lot of times it takes people, and this is a research thing too, 11 times to be asked if they have any trauma history. Totally. And so you just never know. So we have to come in with that lens of like, everyone has trauma until proven otherwise. Sure. You know what I mean? Smart. Yeah. Smart. Well, what else, Doc? What else do you want to chat about? I feel like we covered a lot of ground. This was a fire hose to the face. But
so fun.
What else? Is there anything else you would add to our conversation? This is really cool.
Yeah, I just think it's really important for people to know that it exists. Mm-hmm. I think that's our number one thing is like people don't know we exist. And if they do, they don't know what we do. And to know that there's hope, health, and healing. And we're definitely part of the team and would love to like help be part of someone's journey to that. It's the most rewarding thing that we do is help people accomplish those goals that they have and get back to moving their bodies, be confident in their bodies, and be able to do the things they love, because then they can go on and serve their communities and families. You know what I mean? It's a ripple effect. And so, we're truly changing the world one pelvic floor at a time.
Yes, exactly. That's your motto.
Yes.
Tell us about your shop. What is it called? And then how we might get a hold of you or your team. Totally. And then how maybe even like an OB or myself might refer to you.
Yeah. Absolutely. So we are Reborn Pelvic Health and Wellness. We have 3 locations. We have Lehigh, Murray, and Layton. We have 12 PTs, like I said. And our website is www.rebornphw for pelvic health and wellness.com. And you can just go to our website, give us a call, send us we have a chat. You can submit a request or whatever, and then our front desk would get you scheduled. And then as far as physicians referring and things like that, we have referral pads. You can just fax it over to our fax number. You could text us and be like, hey, give this patient a call. Well, whatever way, we're used to receiving things in all different directions. We'll make sure the patient's taken care of. And then from a personal note, if you want a certain way for us to communicate with you, generally just fax over things with updates. But I have some docs that are like, don't fax me anything unless it's like someone's bleeding or dying because they get so much communication. And we have other people who are like, here's my cell phone, like text me an update, so it's all over the board. So we just want to meet the providers wherever they're at and what their communication style is.
Do you do cash, insurance?
We're a hybrid. Mm-hmm. Yep, hybrid practice. So we do take some insurances in network, and then we bill everything else out of network. And then we also have cash as well as care credit too. So if someone needs a medical payment plan with 0% financing, we do that too.
Oh, you guys have those? Mm-hmm. Oh, that's pretty cool.
HSA, FSA, all things.
Yeah, that's cool. Can you speak to the out-of-network space? Because I don't think a lot of people know what that means.
Right,
and so
right.
Do you guys give them the information to submit a claim?
No, we do it for them.
Okay.
Yeah. So, there's a common misconception around out-of-network. So most people think they hear out-of-network like, oh, you don't take my insurance, which is not true. We're just using a different side of your insurance. So you have two arms of your insurance. You have your in-network and you have your out-of-network. Both are your insurance. So with some of them, we're in-network, and some in other chunk, we're out-of-network. So we actually take payment from you at the beginning of service for out-of-network, and then we submit all the claims for you to your insurance company. And then for your out-of-network benefits, some out-of-network benefit plans actually go towards your in-network things. So they end up getting
full reimbursement,
good chunk reimbursement, or goes towards their deductible or whatever. And then we do have some people like they're getting payments like reimbursement back because we're submitting to their out-of-network.
Oh, cool.
Yeah.
And you just submit it so that they reimburse the patient, not you guys.
Mm-hmm. Well, that's the hope is that they send it to the patient, but they send it to us usually, and then we just give it to the patient. Yeah.
That's really cool.
Yeah.
That's really cool.
Yeah.
That's really neat. I think just understanding the workings there is really good for clients to understand how that all works.
Yeah.
Okay, well, great. Thank you so much for our conversation. Was there anything else that in closing, like just health and wellness, anything you would?
No, I mean, I could talk for days, but
I know.
I think we covered a good chunk of ground today.
Yeah. Well, thank you for your time,
Dr.
Delass. This was really fun.
Yeah.
I learned some cool things about pelvic floor. I think bringing this up on a lot of people's radar, family docs, OBGYNs, midwives.
Absolutely.
I think it would be super, super good. And
Absolutely.
those are probably all your love group of referral network and stuff.
Yep. So I love meeting people. I love, especially when it's people like you and we're on the same wavelength, righteous anger. We're going to ruffle some feathers and make it a better world out there and just care for our patients deeply and with holistic care. So if anyone's out there listening to that and you fit that bill, like I'd love to meet you.
Totally. Yeah. That's our people.
Yeah. Those are our people.
Well, thank you so much for your time. And I just appreciate you and all the work that you do.
Yeah. Same to you.
Thanks.